of personality, paraphilic and substance-related disorders. 207. 8.0 Introduction. So far, you have learnt the defining criteria of psychological disorders according to DSM-5 classification. Moving further, you learned about the clinical aspects of anxiety disorders, psychotic disorders, somatic symptoms disorder, mood disorders and eating disorders. Their causal factors and treatment methods were also discussed. It must be clear by now that the mentioned disorders are not a part of an individual's basic personality structure. This means that after treatment, the person can return to his day-to-day functioning. On the other hand, personality disorders are different. Personality disorders are related to 1. Personality structure. Personality disorder is the normal way of functioning by the person. Personality disorders are classified into cluster A, B, and C. In this unit, you will learn about cluster A personality disorders, that includes paranoid personality disorder, schizoid personality disorder and schizotypal disorder. Their causal factors and treatment will also be discussed. Cluster B and C personality disorders will be explained in the subsequent unit. 8.1 Defining personality disorders. Personality of an individual can be understood as a set of unique traits and behaviors that describe and characterize the individual. These typical traits, coping styles and behaviors usually emerge during childhood and then become established patterns by early adulthood. These characteristics or blend of characteristics make a person unique. Weinberg and Gould, 1999. The continuity, constancy, consistency and stability of these traits and dispositions over time define personality development. Larson and Buss, 2008. It has also been agreed upon that the 5 trait dimensions, neuroticism, extroversion, introversion, agreeableness, antagonism, openness to experiences and conscientiousness, John and Naumann, 2008, McRae and Costa, 2008, can be used to define personality. The personality disorders are a heterogeneous group of disorders. They are usually characterized by problems in forming a stable positive sense of self and sustaining close and constructive relationships. According to DSM-5, a person is to be diagnosed with personality disorder if there is significant impairment in self, identity or self-direction, and interpersonal, intimacy or empathy functioning. The person's enduring pattern of behavior must not be flexible and should be pervasive, stable and longer in duration that deviates from the individual's cultural expectations. It should cause clinically significant distress or impairment in functioning in various areas of life and should be manifested in at least 2 of the areas: cognition, ways of perceiving self, others and events, affectivity, range, intensity and appropriateness of emotional response, interpersonal functioning or impulse control. It has been understood and agreed upon that people with personality disorders cause difficulty in their own lives as well as that of the others. Others usually find their behavior confusing, unpredictable, vexing and also unacceptable at times. The pattern that they have developed over time color their perception totally, thus determining their reactions to newer events and situations in the same light, repeating their maladaptive patterns over and over again. The category of personality disorders encompasses a broad range of behavioral problems which may differ in their form and severity. DSM-5 categorizes them into 3 clusters on the basis of important similarities amongst the disorders. Cluster A. It includes paranoid, schizoid and schizotypal personality disorders. These disorders involve thinking and behavior which appears unusual, odd and eccentric to other people and may often lead to various social problems. It may range from distrust to suspiciousness and even social detachment. Cluster B. It includes histrionic, narcissistic, borderline and antisocial personality disorder. These disorders involve tendency of the individual, diagnosed with it, to be dramatic, erratic, unpredictable and also emotional. Cluster C. It includes obsessive compulsive, avoidant and dependent personality disorders. These disorders involve tendencies to be anxious and fearful. 209. Personality disorders, Cluster A. Often people are diagnosed with more than one personality disorders and as per research, disorders in the same cluster tend to co-occur. Lenzenweger, Lane, Loranger, and Kessler, 2007. Personality disorders first appeared in DSM-3 on Axis 2 in 1980. Axis 2, Since then, till DSM-IVTR has been used to assess disorders, personality disorder and intellectual disabilities, that are usually long-standing or lifelong problems that first arise or encountered in childhood and are different from Axis I difficulties, the standard psychiatric syndromes which were coded on Axis I. But people can have disorders of Axis I which are symptomatic of Axis II disorders. For example, a person may have depression, Axis I, which could be a result of dependent personality disorder. The use of clusters has been a part of personality disorder since then and has also been questioned a lot for its validity. Due to various overlaps across categories and clusters, Kruger and Eaton, 2010, Sheets and Craighead, 2007, it was proposed to remove the cluster organization from DSM-5. But they have been used as an organizing rubric, providing a lot of convenience in understanding them, and thus has been discussed as clusters here despite the fact that axial system has been abandoned by DSM-5. So, now, personality disorders are included with rest of the disorders. The epidemiological studies to understand the prevalence of personality disorders have been very few, especially in comparison to other disorders, but whatever few exist have differing conclusions. Lenzenweger, 2008. Prevalence for one or more personality disorders have ranged from 4.4 to 14.8%. Grant, Stinson, Dawson, Cho, and Ruan, 2005. Paris, 2010. The difference and discrepancy could be due to problems in diagnostic criteria and its clarity. Box 8.1. Difficulties in diagnosing personality disorder. Diagnostic criteria for personality disorders is neither sharply nor clearly defined as they are for other diagnostic categories. A lot of judgment is required on the part of the clinician, as the criteria for personality disorders is defined mainly by inferred traits, Samuel and Weidegger, 2008, or consistent patterns of behavior rather than objective behavioral standards. Some of the personality diagnoses are not very common in the community setting or even most clinical settings. They are found in less than even 2% of the patients. Zimmerman, Rothschild, and Chelminsky, 2005. Many people who may seem to have some personality-related issue may not fit any of the personality disorder categorization or diagnosis in particular. Thus, the dimensional approach is the best suited here. Research suggests that people diagnosed with personality disorders at one point in time when interviewed after 2 years qualified for another diagnosis, though they may have some of the symptoms of the previous diagnosis. McGlashan, Grillo, Sanislo, Relevsky, and others, 2005. Diagnosis made on the basis of structured interviews or self-report inventories have been found to be low on reliability and validity. Trull and Durrett, 2005. A unified dimensional classification has been emerging and attempt has been made to integrate various existing approaches in 210. Disorders of personality, paraphilic and substance-related disorders. Order to make the diagnosis more reliable and accurate. Kruger, Eaton, Clark, 2011. The most influential of them being the 5-factor model based on 5 basic personality traits. Within the dimensional approach, an attempt was made to recast the personality traits to correspond to the pathological extremes: negative affectivity, neuroticism, detachment, extreme introversion, antagonism, very low agreeableness, disinhibition, very low conscientiousness. Psychoticism was not found to be the pathological extreme of openness, rather it reflected traits similar to psychotic disorders. Schizotypal, Watson, Clark and Chmielewski, 2008. Box 8.2. Difficulties in studying the causes of personality disorder. Personality disorders did not receive any formal attention till they were added in DSM-3 in 1980. Thus, the work itself began later in comparison to other disorders. A major issue is that a high level of comorbidity is found among them. Zimmerman and his colleagues, 2005, reported that almost 45% of the 900 patients, their sample, qualified for at least one personality disorder, and out of these, 45%, almost 60% qualified for more than one and 25% qualified for 2 or more personality disorders based on the given clinical criteria. Due to the high levels of comorbidity, it gets difficult to conclude which causal factors are associated with which particular personality disorder. Researchers were found to have more faith in the prospective studies. People are observed before a disorder occurs and are followed to see who develops what problem and what could be the possible reasons behind it. However, a vast majority of research is conducted on people who already have the disorder, so understanding is based on either the retrospective recalls or current observation of biological, emotional, cognitive and interpersonal functioning. Thus, the conclusions could be very preliminary and tentative. Infants' temperament may predispose them to development of a particular trait and thus a disorder in consequence. Paris, 2012. It lays foundation for development of personality as an adult, but other factors may also be responsible for it. For most disorders, it has been found that the genetic contribution is mediated by genetic contribution to primary trait dimension most implicated in each disorder rather than to the disorders themselves. Livesley, 2005. Kendler and others 2008 is cited in Butcher, Hooley, Manika, 2013. Researches are being attempted to understand the psychobiological layer of the traits mainly seen to be involved in personality disorders. Depew, 2009. Paris, 2005, 2007. Roussos and Siver, 2012. With the ultimate goals of reaching an enriched biopsychosocial understanding, apart from these biological causes, psychoanalytic, learning-based models, cognitive patterns, attachment styles, social patterns, cultural values etc. have also contributed to the understanding. 211. Personality disorders. Cluster A. Check you progress 1. 1. Define personality disorders. Thank you for listening. Please like and subscribe our channel. 2. List the clusters of personality disorders. Thank you for listening. Please like and subscribe our channel. 3. Name the personality disorders included in Cluster A. Thank you for listening. Please like and subscribe our channel. 8.2 Cluster of personality disorders. The main symptoms of Cluster A are social awkwardness and social withdrawal, dominated by distorted thinking patterns. It is also known as the odd, eccentric cluster. People falling in this cluster may display unusual behavior, for instance, suspiciousness and distrust as well. In Cluster A, we will discuss paranoid, schizoid and schizotypal personality disorders here. 8.3 Paranoid personality disorder. Being wary of people, questioning their motives is not very uncommon and can also be adaptive. But being too distrustful and questioning anyone and everyone each moment can impact relationships. It can interfere working with others or in groups, with making friends and many other aspects of life which involve interaction with people on a daily basis. They usually assume that people out there, in the world, are to harm or trick them and thus they do not confide in them. The defining feature of this disorder is the persistent and justified distrust. Edens, Marcus, and Mori, 2009. People with paranoid personality disorder usually get suspicious even in the situations where most people would find their suspicions to be unfounded. They may interpret the events unrelated to them or remotely related to them as personal attacks on them. Bernstein and Uceta, 2007. This makes their interpersonal relationships very difficult and strained, as this distrust often extends even to the close family members. They see themselves as completely blameless. Instead, they put the blame on other people, guilty even for their own mistakes and failures. Thus, they may always look on guard and expect trickery from others, which forces them to look for cues to validate their false expectations. They are usually argumentative, may complain or may remain quiet, but are commonly seen to bear grudges, refuse to forgive insults that they may have perceived, and may also get violent. Bernstein and Uceta, 2007, Edens and others. 212. Disorders of personality, paraphilic and substance-related disorders. 2009, Falcom and others, 2009. They are in touch with reality, although may experience certain transient psychotic symptoms during stress. Also, they are more likely and liable for schizophrenia. Lenzenweger, 2009. Box 8.3, DSM-5 Criteria for Paranoid Personality Disorder, APA, 2013, A. A pervasive distrust and suspiciousness of others such that their motives are interpreted as malevolent, beginning by early adulthood and present in a variety of contexts, as indicated by 4 or more of the following. 1. Suspects, without sufficient basis, that others are exploiting, harming, or deceiving him or her. 2. Is preoccupied with unjustified doubts about the loyalty or trustworthiness of friends or associates. 3. Is reluctant to confide in others because of unwarranted fear that the information will be used maliciously against him or her. 4. Reads hidden demeaning or threatening meanings into benign remarks or events. 5. Persistently bears grudges, that is unforgiving of insults, injuries, or slights. 6. Perceives attacks on his or her character or reputation that are not apparent to others and is quick to react angrily or to counterattack. 7. Has recurrent suspicions, without justification, regarding fidelity of spouse or sexual partner. B. Does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, or another psychotic disorder, and is not attributable to the physiological effects of another medical condition. Note: if criteria are met prior to the onset of schizophrenia, add premorbid, that is, paranoid personality disorder, premorbid. 8.3.1 Causal Factors. The evidence of biological contribution to paranoid personality disorder is very limited. Arguments have been made about the partial genetic transmission linking it to schizophrenia, but there are no conclusive or consistent researches pointing at the same. Kendler, Tchaikovsky, Tams, Torgerson, Agin, Neal, and Reichborn 2006. Researchers have also suggested that this disorder is slightly more common amongst the relatives of people with schizophrenia, Tainari and others 2003. Although the associations are not very strong, it may also occur through the heritability of high levels of neuroticism or even antagonism, traits in paranoid personality disorder, Hopwood and Thomas, 2012, Kendler and others, 2006. As far as psychological contributions are concerned, retrospective researches suggest that mistreatment and traumatic childhood could play a role in development of paranoid personality. Natsuaki, Cicchetti and Rigash, 2009. Parental neglect, abuse and exposure to violence could also be responsible. 213. Personality disorders, Cluster A. Freeman and colleagues, 1990, discuss some basic faulty and maladaptive assumptions these people may have about others. People are malevolent and deceptive, they'll attack you if they get the chance. Some researchers have pointed that these assumptions are built due to their early upbringing, as they are asked to be careful, vigilant and on their toes all the time. Carroll, 2009. Certain cultural factors have also found to be playing role in paranoid personality disorder. Groups of people, such as refugees, prisoners, older adults, are considered to be susceptible to this disorder due to their unique experiences. Rogler, 2007. Cognitive factors may also interact with cultural factors. For instance, a refugee with language barrier who is looked at differently by others may always be suspicious and wary of people around them. 8.3.2 Treatment. One of the major impediments in their treatment is their distrustful relationship, due to which they are unlikely to develop a warm, trusting and meaningful relationship with their therapist. Skodal and Gunderson, 2008. If they go and seek treatment, it is usually due to some other problem they might be facing, like depression or some sort of anxiety. It is rarely due to their personality issues that they would seek treatment themselves. Cognitive therapy is widely used to challenge and counter their faulty thinking patterns, with an emphasis on changing the belief that most people cannot be trusted and most people are there to harm them. Skodal and Gunderson, 2008. Still, there are no confirmed demonstrations that any form of treatment could significantly improve the lives of people with paranoid personality disorder. 8.4 Schizoid personality disorder. The term schizoid was used by Bleuler, 1924, in order to describe people who had a tendency to turn away from the outside world. People with schizoid personality disorder demonstrate a pervasive pattern of social detachment and an extremely restricted range of emotional expression, and thus remain socially isolated. They do not usually seek out for relationships on their own, and are most often cold, aloof, and indifferent to people around them. People with schizoid personality disorder are not interested in maintaining close relationships with others, neither romantic nor sexual relationships. Thus, they appear to be cold, distanced and detached people who are neither affected by praise nor by criticism. Homelessness also appears to be common in these people. Ralph, 2000. The social deficiencies found in people with schizoid personality disorder are more extreme as compared to individuals having paranoid personality disorder. They consider themselves to be observers rather than participants in the world around them. Freeman, Pretzer, Fleming, and Simon, 1990, p.125. They appear to be socially inept and superficial due to their indifference towards social cues and nuance and are often classified as loners and introverts. Here, it is very important to mention and emphasize that all loners or introverts are not people with schizoid personality, Bernstein and others, 2009. As they are not emotionally reactive, they rarely experience strong emotions, positive or negative, rather they show apathetic mood. 214. Disorders of personality, paraphilic and substance-related disorders. On the 5-factor model, they show high levels of introversion, being low on warmth, positive emotions and gregariousness, low levels of openness to feelings, Weidegger, Trull and others, 2002, and are also found to be low achievement striving as well, Hopwood and Thomas, 2012. Like the other two disorders of Cluster A, the thought process of individuals with paranoid personality disorder is not that unusual, Cloninger and Svakik, 2009. Table 8.1. Grouping schema for Cluster A disorders psychotic-like symptoms. Cluster A personality positive, example. Ideas negative, example. Disorder of reference, magical poor rapport, social. Thinking. Perceptual isolation and distortion, constricted affect. Paranoid yes schizoid no yes schizotypal yes no. Source. Adapted from Siver, L.J., 1992. Schizophrenia spectrum personality disorder. As cited in Barlow, D.H., and Durand, V.M., 2012. Abnormal Psychology, an Integrative Approach, 6th. ed. 8.4.1 Causal Factors. Extensive research is yet to be conducted to understand the genetic, biological and/or psychosocial causal factors to schizoid personality disorder. Phillips, Yen and Gunderson, 2003. Some theorists and researchers are of an opinion that the disruption in sociability could be due to some sort of impairment in the affiliative system. Depew and Lenzenweger, 2005. Childhood shyness may also act as a predispositional factor to schizoid personality disorder later as an adult. Childhood abuse and neglect have also been reported in the retrospective studies among the individuals with this disorder, Johnson, Bromley, and McGeoch, 2005. Some researchers have also indicated that parents of children with autism are likely to have this disorder, Constantino and others, 2009. There is a possibility a particular biological dysfunction may play a role in both autism and schizoid personality disorder, and that gets combined with some early difficulties like aspects of interpersonal relationships which impact the social interaction of the individual. Cognitive theorists have suggested that the maladaptive schemas of these individuals lead them to be self-sufficient loners and look at others as intrusive people. Their core dysfunctional belief might be, "I am basically alone," Beck and others, 1990, page 51. The reasons behind development of such defeating and faulty schemas are not yet fully researched upon. Box 8.4, DSM-5 Criteria for Schizoid Personality Disorder, APA, 2013, A pervasive pattern of detachment from social relationships and a restricted range of expression of emotions in interpersonal settings, beginning by early adulthood and present in a variety of contexts, as indicated by 4 or more of the following. 1. Neither desires nor enjoys close relationships, including being part of a family. 215. Personality disorders. Cluster A2, almost always chooses solitary activities. 3. Has little, if any, interest in having sexual experiences with another person. 4. Takes pleasure in few, if any, activities. 5. Lacks close friends or confidants other than first-degree relatives. 6. Appears indifferent to the praise or criticism of others. 7. Shows emotional coldness, detachment, or flattened affectivity. B. Does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder, and is not attributable to the physiological effects of another medical condition. Note: if criteria are met prior to the onset of schizophrenia, add premorbid, that is, schizoid personality disorder, premorbid. 8.4.2 Treatment. Usually people with schizoid personality disorder rarely come for treatment unless it is a response to some crisis such as losing a job or some other extreme issue. Kelly and others, 2007. Therapy usually starts with making them understand value in social relationships and may also be taught about empathy and understanding others. Skodal and Gundaran, 2008. Thus, they may receive training in social skills development. They are taught to identify a social network, a person or those who would be supportive to them. Bender, 2005. Check your progress. 2.1. According to DSM-5, list the criteria for schizoid personality disorder. Thank you for listening. Please like and subscribe our channel. 2. Briefly explain the psychological causes of paranoid personality disorder. Thank you for listening. Please like and subscribe our channel. 8.5 Schizotypal personality disorder. Schizotypal personality disorder is characterized by excessive introversion, along with social and interpersonal difficulties. They tend to have perceptual and cognitive distortions, suspicious, Cloninger and Svakik, 2009, and odd behavior, Quapel and Barantes Vidal, 2012. Their contact with reality is usually intact, but under extreme stress they may also experience certain transient psychotic symptoms. APA, 2013. 216. Disorders of personality, paraphilic and substance-related disorders. Schizotypal personality disorder is on a continuum with schizophrenia, but here there is absence of certain symptoms such as hallucinations and delusions. They often come as bizarre to others due to their odd ways of dressing, relating to others and the way they think and behave. They may have ideas of reference and yet may be able to acknowledge the unlikeliness of it. People with schizophrenia too have ideas reference, but they cannot test reality, unlike individuals with schizotypal personality disorder. They may believe in magical thinking or believe that they have magical powers like being a clairvoyant. They may even report unusual perceptual experiences but do not have extreme perceptual distortions like people with schizophrenia. Schizotypal personality disorder has been understood as an attenuated form of schizophrenia. Lenzenwerger, 2010. Bizarreness and oddities in thinking, speech and other behaviors are the characteristic features of schizotypal personality disorder. McGlashan and others, 2005. Some aspects of schizotypy such as introversion and neuroticism can be explained through the five-factor model of personality. However, the aspects related to cognitive and perceptual distortions cannot be explained through the model. Watson, Clark, Chmielewski, 2008. Especially, unusual beliefs and experiences, eccentricity and cognitive and perceptual dysregulation. Kruger, Eaton, Derringer, Markson, Watson, and Skodal, 2011. It is important for mental health professionals to practice caution, especially when dealing with certain cultural practices which may differ from their own and thus may look distorted or may look like an odd behavior before giving a final diagnosis. Box 8.3. DSM-5 Criteria for Schizotypal Personality Disorder, APA, 2013. A pervasive pattern of social and interpersonal deficits marked by acute discomfort with, and reduced capacity for, close relationships as well as by cognitive or perceptual distortions and eccentricities of behavior, beginning by early adulthood and present in a variety of contexts, as indicated by 5, or more, of the following. 1. Ideas of reference, excluding delusions of reference. 2. Odd beliefs or magical thinking that influences behavior and is inconsistent with subcultural norms, example, superstitiousness, belief in clairvoyance, telepathy, or sixth sense in children and adolescents, bizarre fantasies or preoccupations. 3. Unusual perceptual experiences, including bodily illusions. 4. Odd thinking and speech, example, vague, circumstantial, metaphorical. Over-elaborate or stereotyped. 5. Suspiciousness or paranoid ideation. 6. Inappropriate or constricted affect. 7. Behavior or appearance that is odd, eccentric, or peculiar. 8. Lack of close friends or confidants other than first-degree relatives. 9. Excessive social anxiety that does not diminish with familiarity, and tends to be associated with paranoid fears rather than negative judgments about self. 217. Personality disorders, cluster AB. Does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder. Note: if criteria are met prior to the onset of schizophrenia, add premorbid, example, schizotypal personality disorder, premorbid. 8.5.1 Causal Factors. A review of studies has suggested that the prevalence of schizotypal personality disorder in the general population is about 2 to 3%, Rain, 2006, with a moderate heritability, Quapple and Barantes-Vidal, 2012. A genetic relationship of schizotypal personality disorder has long been suspected with schizophrenia. It has been found that it is a part of the spectrum of liability for schizophrenia that occurs in first-degree relatives of people having schizophrenia, Quapple and Barantes-Vidal, 2012, Rain, 2006. Teenagers with schizotypal personality disorder are at high risk of developing schizophrenia and/or schizophrenia spectrum disorders. The biological association between the two disorders has been understood by various studies and researches. Both have been found to have a deficit in the ability to visually track a moving target. Coquero, 2001, deficits in ability to sustain attention. Rain, 2006, deficits in working memory. Farmer, O'Donnell, Niznikovich, Vogelmeyer, McCarley, and Shenton, 2000, and language abnormalities which could be related to abnormalities in their auditory processing. Dickey, Marax, Niznikovich, Vogelmeyer, Tone, Kahn and others. 2008. Another aspect to that has been proposed is that there is a second subtype which is not genetically linked to schizophrenia and is characterized by cognitive and perceptual deficits. It might be linked to history of early childhood trauma and abuse. Rain, 2006. Low family socioeconomic background and exposure to stressful events could also be the contributors. Tessner, Middle, and Walker, 2011. 8.5.2 Treatment. It has been estimated that almost 30 to 50% of the people with schizotypal personality also meet the diagnostic criteria for major depression. Thus, their treatment also involves the ones given to people with major depression. The interest is slowly increasing in looking for treatment methods and strategies for schizotypal personality gradually, as it is also viewed as a precursor to schizophrenia. Some studies have used antipsychotic medication, community treatment and social skills training as a combination to treat people with this disorder. And it has been found that using this approach has either reduced the symptoms or has delayed the onset of later schizophrenia. Nordentoft and others, 2006. Check your progress. 3.1. List the main characteristics of schizotypal personality disorder. Thank you for listening. Please like and subscribe our channel. 218. Disorders of personality, paraphilic and substance-related disorders. 2. Suggest treatment options for schizotypal personality disorder. Thank you for listening. Please like and subscribe our channel. Thank you for listening. Please like and subscribe our channel. 8.6 Summary. Now that we have come to the end of this unit, let us list all the major points that we have already learned. Personality disorders indicate an inflexible and distorted behavioral pattern resulting in maladaptive ways of perceiving, thinking and relating to others and their environment. DSM has categorized personality disorders into 3 clusters, and the validity of this categorization has been questioned. DSM-5 has not used this categorization, but this has been used due to commonalities shared by disorders categorized under each cluster. Cluster A includes paranoid, schizoid, and schizotypal personality disorders. The characteristic features of this disorder are eccentricities or oddities. Genetic and biological causes are implicated in schizotypal personality disorder, but the research around causes of paranoid and schizoid disorders is relatively less. Cluster B includes histrionic, narcissistic, antisocial and borderline personality disorders. People falling in this cluster are found to be emotional, erratic and dramatic. Research in the area of histrionic and narcissistic personality is very scant, but certain biological and psychosocial factors have been researched upon to understand the causality of borderline and antisocial personalities. Cluster C comprises of avoidant, dependent and obsessive compulsive personality disorders. This cluster characterizes fearfulness, tension, shyness and anxiety-based symptoms. Inhibited temperament may increase the risk for avoidant personality, and those high on traits such as neuroticism and agreeableness may increase risk for dependent personality disorder, especially when faced with authoritarian and overprotective parenting styles. 8.7 Keywords. Personality, a set of unique traits and behaviors that describe and characterize the individual. Personality disorder, any significant impairment in self, identity or self-direction, and interpersonal, intimacy or empathy, functioning. 219. Personality disorders. Cluster A. Cluster A. Disorders involve thinking and behavior which appears unusual, odd and eccentric to other people and may often lead to various social problems. It may range from distrust to suspiciousness and even social detachment. Cluster B. Disorders involve tendency of the individual, diagnosed with it, to be dramatic, erratic, unpredictable and also emotional. Cluster C. Disorders involve tendencies to be anxious and fearful.